All right, I think we can go ahead and get started. This is the Department of Medicine internal grand rounds. Today is October 21st, 2021. Today's discussion is going to be the first of our Clinical Pathological Conference series, our CPC series. And in a second, I'll turn it over to one of our chief residents, Dr. Zoe Zhang, who will introduce the concept of CPC as well as our guest lecturers today. Just briefly, a couple of quick remarks. We are still virtual, so thank you all for participating virtually. Eventually, we will get back in person. Just virtually things, the CME code will be up in the chat box in a minute, as well as the New Innovations QR code will be put up at the end of the presentation again. We also have the ability to chat and interact with our expert speakers. You can either use the chat box, the Q&A function, or you can ask to be unmuted and raise your hand, and we will get to you at the last 5 to 10 minutes of the conversation. A couple of quick things. If you have any technical assistance or issues, either myself or Thomas Bryan are available. You can message us in the chat box and we can troubleshoot that. A couple of quick things and call outs. There was the ACP Virginia conference last week, the resident abstract competition. We just want to highlight Patrick Willard, who got first place overall in the clinical vignettes, and Dan Park, who got second place overall in the research series. So congratulations to you all. That occurred last weekend on Saturday, October 16th. Coming up, just a quick thing, the annual department chili party and cook-off is on November 6th, which is 2 weeks from this Friday. It is at Dr. Barrett and Dr. Call's house, starts at 4 o'clock on Saturday, November 6th. Hope to see everyone there. For now, I will turn it over to Dr. Zhang, who's going to present the CPC conference series and introduce our speakers. Thank you all so much.
Hi, good afternoon, everyone. Let me just share my screen first. So can everyone see my slides? All right, so was that a yes? Okay, so my name is Zoe Zhang. I am one of the chief medical residents in the Department of Internal Medicine, and it is my great pleasure to kick off the first Clinical Pathological Conference of this academic year. For those of you who have not been to our Clinical Pathological Conference, I just wanted to give an overall outline of today's conference. I will be giving this introduction and case overview. That will be followed by our case discussion and dissection by our faculty discussant, Dr. Michael Leroux, whom I will introduce at the end. And following that, we will have a content expert discussion by our content expert, who I will also introduce later. We will leave 5 minutes at the end for questions. The objective of the CPC conference is really for the audience to identify key components in the patient's presentation, relevant findings in the history and physical exam, as well as in the diagnostic workup of the patient. Our goal is also to generate a differential diagnosis using a system-based approach, starting thoughtfully broad, but ultimately narrowing down to a single diagnosis. And finally, we want to use evidence-based medicine and critical reasoning to support the diagnostic approach. So today's case is on a 26-year-old Ethiopian man presenting with progressive fatigue, poor appetite, 10-kilogram weight loss, and yellowing of the eyes and skin over the past 6 months. He notes intermittent right upper quadrant pain without clear aggravating or alleviating factors. And around the same duration of time, he notes darker urine, but without hematuria, dysuria, or flank pain. He has no fevers, chills, night sweats, nausea, vomiting, hematemesis, hematochezia, or melena. He has no episodes of confusion, and he has no recent travel, zoonotic exposures, or medication changes. Prior to the onset of these symptoms, he has suffered since childhood from intermittent recurrent pain and swelling in his bilateral hands. This is associated with a tender, hyperpigmented, purplish rash with blistering over the dorsum of the hands. He denies any skin breakdown, purulence, or erythema. The rash used to bother him all the time back in Ethiopia, but now in Richmond, he says it is worse in the summer and better in the winter. And it is associated with some chronic changes on the skin, such as dryness, tightness, and thickening over his dorsal hands. He denies any irritant or topical exposures to his knowledge. On review of systems, he notes fatigue, poor appetite, and weight loss, but denies fevers, chills, night sweats. He notes yellowing of the eyes, but no dry eyes, eye pain, discharge, or vision change. He does have dyspnea on exertion, but no cough, wheezing, or hemoptysis. His cardiovascular review of systems is negative. He does have right upper quadrant abdominal pain as noted prior. He denies any dysphagia, nausea, vomiting, or really any other GI symptoms. He does have dark urine, but no dysuria, hematuria, flank pain, or any genital lesions. He has bilateral hand pain associated with swelling, but no myalgias or morning joint stiffness. He has the rash on his dorsal hands, as well as generalized yellowing of the skin. The rest of his review of systems is negative, as noted. On his past histories, his past medical history is notable for skin inflammation and arthritis in the hands since childhood. He has no surgical history. His mother has arthritis and dermatitis of unspecified type since adolescence. His father is healthy. He has one healthy brother. There is no family history of liver disease, rheumatologic disease, or cancer. On social history, he denies any tobacco use or illicit drug use. He does have a history of heavy alcohol use, about 3 to 4 shots of liquor a day, and he started drinking since a very young age of 9 years old. He said that in the past year, though, he has cut down to 1 beer or 1 shot of liquor a week. He is not currently sexually active and denies any history of STIs. He has no history of blood transfusions, tattoos, or piercings. He lives in Richmond. He moved here from Ethiopia in 2019. He currently works at a 7-Eleven. He was a student back in Ethiopia. And the only medication he takes is Tylenol 500 milligrams 1 to 2 times a day as needed for pain, and he has no medication allergies. On his physical exam, his vital signs were all within normal. His BMI is low at 17.6. His general appearance, he is not in any distress. He is alert, well-groomed, he is sarcopenic. On his HENT exam, he does have sublingual jaundice. He has sclera icterus. And then in terms of cardiovascular exam, he has normal rate and rhythm, normal S1 and S2 without murmurs, rubs, or gallops. He has 2+ peripheral pulses, no peripheral edema, and no elevation in JVP. His lungs were clear to auscultation bilaterally with normal work of breathing. His abdomen is soft, non-distended, mildly tender in the right upper quadrant, and he had normal bowel sounds, no shifting donuts, and no fluid wave. His liver edge is percussed at 2 centimeters below the rib cage. He had no splenomegaly by percussion and a negative Murphy sign. On his MSK exam, his joints had full range of motion and there were no obvious joint deformities. He also had no joint tenderness, effusion, warmth, or erythema, and his muscles were non-tender. His neurologic exam was all within normal limits, and notably, he had no asterixis on exam. His skin was notable for hyperpigmented skin with scattered, crusted over blisters over bilateral dorsal aspects of his hands. And he also had notable generalized jaundice. He had no spider angiomata, no palmar erythema, and he had a normal psychiatric exam. On his basic labs, his basic metabolic panel was within normal limits. His creatinine was 0.6. We also got his cystatin C, which was similar at 0.56. His CPC showed a white count of 9.1, hemoglobin of 11.7, and platelets of 95. He had a differential on that CBC as noted here. His hepatic panel showed a total protein of 8.7, albumin of 4.7, total bilirubin of 8.5, conjugated bilirubin of 5.6, AST of 500, ALT of 601, and ALK Phos of 189. His INR was 1.1, APTT was 31, and his TSH and CK were normal. His urine analysis also was normal. On further serologies and diagnostic workup, his hepatitis viral serologies showed a Hep A IgM that was negative, Hep A IgG that was positive, Hep B surface antibody that was negative, and also negative Hep B surface antigen and core antibody. His Hep C antibody was negative, HIV antibodies were negative, and CMV IgG was positive. We got a ton of rheumatologic labs as well as autoimmune hepatitis labs, and those antibodies were all negative as demonstrated. His IgG level was 1497, his ceruloplasmin level was 20, and his alpha-1 antitrypsin was 153. His iron panel was normal, and his blood cultures were negative. His EKG showed normal sinus rhythm. His transthoracic echo with bubble showed normal biventricular size and systolic function with an EF of 55 to 60%. He had no obvious valvular disease, though the valves were not fully well visualized, and agitated saline demonstrated a right to left shunt, likely at the pulmonary level. And his chest x-ray, both PA and lateral, showed no acute cardiopulmonary abnormalities. And with that, it is my pleasure and honor to introduce our faculty discussant, Dr. Leroux. Dr. Leroux grew up in New Jersey and received his undergraduate education at the College of William and Mary. He attended medical school at VCU and stayed here for internal medicine residency, chief residency, as well as his pulmonary and critical care fellowship. He has been deeply committed to medical education and graduate medical education throughout his training and career, and has been instrumental to key curricular changes and implementations, including our very beloved biannual physiology course. He has recently graduated fellowship training and joined faculty at VCU as an assistant professor within the Department of Pulmonary and Critical Care Medicine, as well as the associate fellowship director. He splits his time between education of residents and fellows and clinical care to patients, both within the pulmonary clinics and the intensive care unit. Thank you so much for joining us, Dr. Leroux.
Thanks for the introduction, Zoe.
And I will stop sharing my slide.
Perfect. All right. So like Zoe said, my name is Michael Leroux, and I am new faculty here at VCU and got a trial by fire of being the first person to do CPC this year. So thanks for that, Zoe. I have no financial disclosures or conflicts of interest to report. I do have the following disclosure though, that I have no clinical expertise in many of the items on my differential diagnosis. I'm sure that was intentional on the part of the chiefs, but hopefully, even if we don't get to the right destination, the journey there will be just as fun. All right, so I'm going to go through the case systematically, and anytime you see green fonts, that's going to be things that I thought were pertinent positives, and red is going to be pertinent negatives. So out of this HPI, the things that I really picked out to be the pertinent positives, so that the patient is originally from Ethiopia, that the patient has a significant unintentional weight loss of 10 kilograms, that he has yellowing of the eyes and the skin, that he has right upper quadrant pain and dark brown urine, and that these things have been going on for 6 months. So already, as I'm thinking through my differential, I'm thinking about things that are more chronic instead of acute processes. The other thing that I thought was important from his history was this purpuric rash with blistering, and that it gets worse in the summer, and has gotten better since he moved from Ethiopia. So that makes me think that this rash is some sort of photosensitive rash, or something that's specifically with the hands, so the distribution might be important as well. As I move on to the review of systems, of course, it's easy to pick out the positives and negatives here. So the positives are what we talked about in the history, but specifically what I thought were important negatives. So the lack of B symptoms I thought was important. for this patient, that the dark urine was not hematuria, or at least not that the patient can report, and the lack of myalgia. So I thought those were all pertinent negatives in the review of systems. As we move next to the additional history that was provided, the pertinent positives, again, the skin inflammation and arthritis, and especially that this has been going on since childhood for this patient. So again, chronicity and something that's been going on for a long time. That the patient's mother had something very similar that started in adolescence also, I think, is really important. And as I think about something that might be hereditary, the lack of a history in the patient's father or the brother, when I think through different ways that genetic diseases are passed along, then the lack of history in a brother and a father helped me with thinking about how something might be transmitted genetically. I also thought that the family history, lack of family history for liver diseases, rheumatologic diseases, and cancers was also pertinent, and that many things that will end up on my differential diagnosis oftentimes can have some sort of family history. Of course, this heavy alcohol use in anyone that's got jaundice is going to be really important to me. Not just that the patient is originally from Ethiopia, but the timeline of when he came. So the fact that he moved here about 2 years ago, I thought was important and will probably come into play in thinking through my differential. And of course, also any time that somebody has jaundice, thinking about Tylenol and how often people can underreport the amount of Tylenol that they're unintentionally taking. So if I put all of these things together and start to form an illness script in my mind, this is what I came up with. So we have a 26-year-old Ethiopian man. He has a history of a presumed familial, chronic, intermittent, photosensitive blistering skin rash, and alcohol misuse who's presenting with chronic fatigue, dyspnea on exertion, right upper quadrant pain, a 10-kilogram weight loss, and jaundice, which is associated with intermittent dark urine. And I think that that sentence really ties in what I thought were the key findings from the history so far. And if I think about this, I can put those into 4 categories of what I think are the key signs and symptoms at this point. 1, that the patient's from Ethiopia, 2, the chronic blistering skin rash, 3, the chronic jaundice, and 4, the dark urine. The next step I'm going to think about with my differential diagnosis is going back to the classic Occam's razor. So I think about my differential of, do I need to find something that fits into that small shape in the middle of these 4 cardinal signs and symptoms? Is there one diagnosis that's going to explain all of these things? But I also have to keep in mind Hickham's dictum that patients can have as many diseases as they want. And so just because they have all these signs and symptoms doesn't mean that they're all related and there's one unifying diagnosis. So I have to keep an open mind in my differential diagnosis. At this point, I also have to start to acknowledge my own biases and think about how these biases are going to play a role in formulating my differential diagnosis and how I interpret data as I go through the rest of the physical exam and the lab findings that were given to us. So the first thing that comes to mind when I start putting together a pattern, when I think about a chronic blistering skin rash, is porphyria. I don't really remember much about porphyria from medical school, but for some reason that popped into the back of my head. And as I'm going through the case, I want to make sure that I don't anchor myself on that diagnosis or come to premature closure. And I have to really keep an open mind as I'm formulating a differential. The other thing is that in the ICU, the majority of the patients that we see with liver dysfunction tends to be due to alcohol abuse. And so I also have to make sure that even though that's the most common thing that I see that's available to me, that doesn't necessarily mean that's what's going on with this patient. So I really have to keep an open mind. I think of this as looking at this optical illusion. And even though my initial inclination is that this is a young woman, you can also interpret this picture as being an old woman. All right, so as we start to go through these signs and symptoms, I'm going to start with the patient is originally from Ethiopia. Now, I'm not an infectious disease doctor, so I had to definitely do some research to remind myself of what comes from Ethiopia. So Ethiopia, as many of you guys No, from geography class is a East African country that is close to the equator. And there are many different diseases that are endemic to that country. And these are divided into arthropod-borne diseases, foodborne and waterborne diseases, and other. The majority of these diseases, however, are going to really present with acute findings, and the patients typically are going to have fevers and other constitutional symptoms that look like they have an acute infectious etiology. So that really helps narrow down immediately from these diagnoses to a couple of ones that can present more chronically. And the ones that I pointed out here are trypanosomiasis, leishmaniasis, schistosomiasis, echinococcosis, TB, the hepatitis, and HIV. So I want to focus on these a little bit more because, again, I don't remember much about many of these things since I haven't seen them in clinical practice. So if we start with human African trypanosomiasis, this is classically the African sleeping sickness transmitted by the tsetse fly. There can be a chronic form of this, but it is more common in West and Central Africa. And when I looked it up, there's actually no reported cases in Ethiopia in over 10 years. So that really goes against this. If you look at the first stage as well, lots of B symptoms and lymphadenopathy, which were not given in the history. And the second stage, of course, being the sleeping sickness that really doesn't fit with our patient. So I think I can narrow this out of my differential diagnosis already. Looking at leishmaniasis, there are a couple of phases to this disease as well. So the initial phase is the cutaneous, where patients get papules or nodules at the bite sites from the sandflies. Now, that's not really what the patient's describing, but I'm certainly terrible at describing skin lesions, so I'm sure our patients are as well. Later on, you can get the visceral phase, which is also known as cala-azar. The incubation phase can be as long as years, which would fit with our patient. Classically, are going to have B symptoms, and then are going to have hepatic dysfunction, jaundice, and HLH. So that certainly could fit with our patient. And post the cala-azar, patients can get hypopigmented macules or papules that come in after treatment. So maybe he did get treated for something as a kid, and now the chronic skin findings are that, although not really described as blisters. Additionally, as I had initially said in my illness script, that I thought this was something familial. And I have to, again, keep an open mind that even though I'm thinking this is familiar, that certainly something like an infectious disease can be present in multiple family members if they have the same risk factors, which you would assume people living together would have. And this is just a picture of the post-cala-azar dermal leishmaniasis. The third disease that I wanted to pick out was echinococcosis. So this is where patients ingest these echinococcus, and then they develop hydatid cysts in different organs. Most commonly, this is going to be in the liver. And if those cysts get large enough, it can cause mass effect, leading to right upper quadrant pain, malaise, weight loss, and jaundice, which of course our patient has. Classically, though, this is not associated with a cyst, with a rash, although it can. And then finally, schistosomiasis. So this also has two phases, an acute phase with an itchy rash and hypersensitivity syndrome, and then a chronic phase, which can present years later, where they have some weight loss, abdominal pain, can develop portal hypertension from hepatosplenic involvement, pulmonary involvement, although our patient wasn't really complaining of pulmonary symptoms, hematuria, which again, our patient denied, but could be confused about whether or not it was truly blood. So these certainly fit with our patient as well, and you can develop skin lesions later on too if the organisms move to the skin. So with that, I'm going to move on to the next key sign, which is a chronic blistering skin rash. Again, as an intensivist and pulmonologist, this isn't necessarily my area of expertise. So I went to visual diagnosis and used that to help work through my differential diagnosis, and also found this great schematic from UpToDate, which is always a great first resource to look at. And really this is a huge differential diagnosis, but what I wanted to focus on was the differential for blisters that are localized to the hands or that are photo distributed. There are many of these things that I had not heard of. So if I just look at 3 of these that I picked out as the most likely for our patient, polymorphous light eruption, epidermolysis bullosa simplex, and palmar plantar eczema seemed like the most likely culprits from that differential diagnosis. There can be genetic susceptibility or even autosomal dominant transmission, which fits with our patient. The thing that doesn't fit, however, is that these largely don't have systemic symptoms. So if these describe what's going on for a patient, it would have to be under the Hickham's dictum of there being 2 etiologies going on, because I don't think these could explain the patient's liver dysfunction. So based upon that, I decided to take kind of the opposite view of looking at the skin rash and thinking about, well, what systemic diseases can be exacerbated by sunlight? And that search gave me this differential of lupus, dermatomyositis, pellagra, carcinoid, cutaneous T-cell lymphoma, erythema multiforme, such as with HSV, different aspects of HIV infection, lichen planus, which can be associated with Hep C, different viral infections and viral exanthems, photosensitivities due to medications, and pseudoporphyria, which can be due to end-stage renal disease or different medications as well. The final thing that I wanted to talk about from this cardinal symptom was the porphyrias. So again, not something that I remember much about, so I had to do quite a bit of research into this. There are 3 kind of main categories that this New England Journal review article brought up. Acute intermittent porphyria, which is classically acute paroxysms of abdominal pain, which doesn't fit with our patient. Protoporphyria, which has a sun-sensitive rash, but is classically not blistering. And then porphyria cutanea tarda. So this is a blistering rash that is associated with dark urine and can be associated with hepatitis C, HIV, iron overload, and the use of alcohol. What doesn't really fit with our patient, though, is the classic age of onset is greater than 40 years of age for porphyria cutanea tarda. So at this point, definitely not a slam dunk diagnosis for our patient. The next piece of the puzzle I wanted to approach was the chronic jaundice. This is kind of my general schematic of looking at differential diagnosis for jaundice. So I start with hyperbilirubinemia, and then my first big junction point is whether it's conjugated or mixed or unconjugated hyperbilirubinemia. Rather than go all the way through this differential diagnosis, I'm just going to cheat and wait and come back to this once I actually look at the labs, and then I can really focus and narrow my differential diagnosis. So based upon history alone, I really can't do much to narrow these things down. The final piece to the puzzle is going to be this dark urine. And a quick differential diagnosis that I came up with for this would be myoglobinuria, such as with rhabdomyolysis or myositis or dermatomyositis. Some of the porphyrias, not all of them. Hemoglobinuria, such as with intravascular hemolysis, which of course can also cause hyperbilirubinemia. Hematuria, beeturia from dietary ingestion of beets. And then different medications can cause different colorations of urine, such as rifampin, phenytoin, and senna. So if I go ahead and try to put all 4 of those things together and start to develop my differential diagnosis based off of history alone, this is the list that I came up with. So under the infectious category, I thought that echinococcosis still fit. Schistosomiasis definitely still fits. Viral hepatitis, of course, is a very common cause of liver disease in our patients. CMV and EBV, HIV and AIDS, TB. Under metabolic, porphyria, mitochondrial disorders, which could cause intermittent rhabdomyolysis, Wilson's disease, hyperthyroidism, hemochromatosis. Under toxic alcoholic hepatitis, Tylenol overuse. There's of course a chance that the chiefs are hiding some secret substance from me. I'm hoping that that's not the case, but always have to keep an open mind that patients sometimes don't think about things like supplements that we've seen cases in the past of acute liver injury and acute liver failure. Hematologic processes like lymphoma, hemolytic anemia, hepatocellular carcinoma, or other obstructive masses such as liver, biliary, and pancreatic masses or cancers. Under autoimmune, I thought dermatomyositis, autoimmune hepatitis, primary biliary cirrhosis, and primary sclerosing cholangitis fit for this patient. I had to put something remotely pulmonary related, so sarcoid can do many things, can affect the liver, and can cause rashes. And of course, have to keep in mind that there might not be one unifying diagnosis. So if I can't find one thing that fits all the signs and symptoms for a patient, then it might be that there's more than one process. So with what I think is a pretty good differential at this point, I'm going to move on to the physical exam. What I thought were pertinent negatives. So the lack of a temperature, again, helps shift me away from a lot of those infectious diseases that could be causing some of his signs and symptoms. The lack of lymphadenopathy might point me away from some of the hematologic processes like lymphoma. The lack of splenomegaly, I think, is probably important. And specifically, there was no findings of end-stage liver disease, such as spider angiomata or pulmonary erythema on the physical exam. So I think the combination of that and the lack of splenomegaly makes me think that the liver dysfunction is probably not progressed to end-stage liver disease based on physical exam alone. There certainly is significant low BMI and sarcopenia. The scleroicterus confirms what we got from history, that the patient does have jaundice. He does have an enlarged liver that is tender, and the rash on physical exam is hyperpigmented, which goes against the post-Kala-Azar rash, and there truly are blisters on a sun-exposed part of his hands. So that does confirm what we were thinking for our differential diagnosis earlier. This is definitely a blistering process. Next, I'm going to go to the labs. So pertinent negatives, again, of the creatinine. I do think it's important that he has a normocytic anemia and thrombocytopenia. So we definitely have to think about those. On the differential, the lack of eosinophilia, I thought, made some of our parasitic infections less likely. When I tried to find what the negative predictive value for that would be, I found a wide range of anywhere from 40 to 95%. So I'm not sure how much that helps me with ruling out parasitic infections. There was a significant monocytosis, which I'm going to have to do some more thinking about. Again, I wasn't given a smear. I'm going to go ahead and assume that the chiefs are not hiding something like schistocytes, abnormal RBCs, or parasites from me. If I look at the hepatic panel, there is a significant elevation in the AST and the ALT with the preserved ALK phos. He has a mixed hyperbilirubinemia and has evidence of preserved hepatic function with the normal albumin and INR. Our thyroid stimulating hormone is normal. CK is normal. We have a relatively bland urinalysis. Lots of autoimmune panels that are negative, as well as a normal ceruloplasmin, alpha-1 antitrypsin, and iron panel. Our hepatitis, or our viral serologies, show a Hep A IgG with a negative IgM, which suggests either a prior infection or that the patient has been immunized against Hep A. And our same thing with our CMV IgG, suggesting that he's been exposed to CMV at this point. But I'm assuming a positive IgM was not hidden from me. So I think the key things I took away from this, and as new things that I really have to focus on, I think I can now say that this chronic jaundice is truly a liver injury that I have to think about and narrow my differential diagnosis for. And then I'm not really sure what to do with this monocytosis. So I think I'm going to have to come back to that and think about that some more. On the imaging, I was not given a right upper quadrant ultrasound, which I think would have been helpful. Again, I'm going to assume that no one is hiding something like a large liver mass from me, but of course that would be helpful for this patient. I'm not sure why we got an echocardiogram, but now I have a new finding of a positive bubble study that I have to contend with. And of course, the chest X-ray is normal, because if it was a pulmonary process, that would only be too easy for me. So as I think about this new problem of the agitated saline with a pulmonary shunt, I think about my differential diagnosis for an intrapulmonary shunt. Largely, these are going to be due to AVMs in the lungs. The most common things that we're going to see for this are liver disease, such as portopulmonary hypertension. Hereditary hemorrhagic telangiectasia is very common. I don't think that really fits with our patient. Traumatic causes, mitral stenosis, which we didn't see on the echo. Schistosomiasis, interestingly, is a cause of this. If the patient develops pulmonary hypertension, which we don't have evidence of on our physical exam. Actino, which we don't see on the chest X-ray, Fanconi syndrome, metastatic thyroid carcinoma, a history of a congenital heart disease surgery, and of course, anything can be idiopathic. So I'm going to go ahead and add that in as another circle in our Venn diagram that I'm going to have to contend with at some point. All right. So now I think I can more easily approach this schematic when I'm thinking about the patient with hyperbilirubinemia and what I'm now calling chronic jaundice with liver disease, liver injury. So the way that I think about a liver injury is really honing down on the numbers. And the three things that I think are the most important here are the pattern of liver injury, or the pattern of elevation in our transaminases, the magnitude of the elevation, and the ratio of AST to ALT. And the combination of those things really can help me with further narrowing down my differential diagnosis. So the way that I look at a pattern for liver injury is looking at the R value. And what you're doing here is comparing the alk phos elevation compared to normal, the ALT elevation compared to normal to the alk phos elevation. For our patient, he has an R value of 9.5 and an R value of greater than or equal to 5 suggests that this pattern of injury is hepatocellular. Again, I tried to find some odds ratios or pretest probability for those, and I couldn't find a great article to support that. But it is a guideline recommended way to evaluate the pattern of liver injury in the hepatology guidelines. The next thing I look at is the magnitude of elevation, because different causes of hepatocellular injury will cause different magnitudes of elevation. Our patient at 601 of the ALT is almost exactly 15 times the upper limit of normal. So that puts us in the severe category, which really helps to narrow our differential diagnosis for different things. And the third thing I look at is the AST to ALT ratio. So like I said earlier in my bias slide was that alcoholic liver disease was certainly on my differential diagnosis, but in a ratio of AST to ALT greater than 2 is highly suggestive of that, and that's not present in our patient. So the next question I asked was, how good of a test is that? And is there anything else that I could use? And I came upon the alcoholic liver disease to NAFLD index. And if you do this calculation for our patient, you come up with 2.748. And a value of greater than 0 does favor alcoholic liver disease with a 94% probability. But anytime we use a test, we always have to think about it, is this the right test to use for our patient? And this test is really to be used in patients that you have ruled out other causes of liver disease, and you're really down to, is it the alcohol or is it the NAFLD? And in our patient with a low BMI, I don't think this really applies to our patient. So I'm not sure how really to interpret this for our patient. And I have to take this result with a grain of salt. So again, going back to our schematic, now I can pretty easily just localize the patient to here. And now I can change my circle for my Venn diagram to chronic marked hepatitis. So now my differential diagnosis for hyperbilirubinemia has really been narrowed down to hepatocellular injury, and within that to something that causes marked elevation and or something that causes chronic hepatitis, because that's also going to narrow our differential diagnosis of acute versus chronic. We talked about the Tylenol, and I'm again assuming that we've asked the patient extensively and that his history of only taking one 500 milligram Tylenol once or twice a day is accurate. There don't seem to be any new drugs to explain this. We've ruled out viral hepatitis with our labs thus far. Alcohol hepatitis, definitely still on our differential diagnosis. Autoimmune hepatitis, Wilson's disease, have also been evaluated with lab tests and so far seem less likely. I didn't get a right upper quadrant ultrasound, but again, I'm assuming that this was not hidden from me as far as an ischemic Budd-Chiari veno-occlusive disease, a malignant process. Help seems unlikely for our patient. Toxins, again, there could be something that's hidden from me, but I'm hoping that that's not the case. And muscle disorders, while they could explain a lot of the patient's findings, such as dermatomyositis, the negative CK seems to point away from that. And then things that can cause chronic hepatitis. So we already talked about viral and autoimmune. Hemochromatosis we've ruled out with our iron panel. And then these other things we've also evaluated with our testing that we've gotten thus far. So I think the only thing that really remains here is alcoholic hepatitis. Now, what about the monocytosis? So this is certainly not something I think about very often when I look at a patient's differential. I look at eosinophils, I look at neutrophils, I look at lymphocytes, so I really had to think about monocytes a lot. So what's considered significant monocytosis is greater than 10% monocytes or greater than or equal to 1 × 10⁹ per liter. The patient was right at 10% and didn't quite hit that 1. And there's a pretty broad differential of things that can cause monocytosis. Probably the most common are going to be these transient things. So bone marrow recovery after something like a bone marrow transplant, any kind of stressor like sepsis or any infection, exercise can do it, an MI, splenectomy, chronic bacterial infections like TB, miscellaneous infections, Kala-Azar can do it, trypanosomiasis, I'm sure among others. Of course, malignancies can do this. And then cirrhosis and liver disease itself can do it, in addition to different autoimmune diseases. So if I think about this, I think that the monocytosis is probably secondary to whatever else the patient has going on. So I'm not sure that I'm really going to include this as a key finding or sign or symptom. I think it's more of a secondary outcome for the patient. All right, so if I try to put it all together, I start with my key signs and symptoms for my history. And now I've got what looks much more confusing of these signs and symptoms with the inclusions of the things that we found on the physical exam and our diagnostic workup thus far. But again, I think I can really say that the diagnosis is probably somewhere in between the chronic blistering skin rash, the dark urine, which now I can say is bland off the UA, and the chronic marked hepatitis. I think the pulmonary AVM is probably secondary to whatever's going on with the liver. I'm not sure that anything truly has convinced me with the infectious diseases that are endemic to Ethiopia, given the patient's presentation. And again, I think the monocytosis is probably secondary. So while those are important to keep in consideration as I narrow my differential diagnosis, I think that the combination of the other three things is where my diagnosis is going to be found, assuming that there's one unifying diagnosis. So if I take those three cardinal findings and go back to my differential diagnosis, echinococcosis and schistosomiasis seem less likely based off both the history and based off of the lack of eosinophilia. We've ruled out our hepatitis, CMV. I wasn't given EBV, but it doesn't really fit either because of the rash. HIV is ruled out. Porphyria is still a possibility. The possibility of a mitochondrial disorder causing rhabdo seems less likely with a normal CK in the setting of a worsening presentation. Wilson's hyperthyroidism, hemochromatosis I've evaluated with my labs. Alcoholic hepatitis, like I said, was still on my differential diagnosis. I'm going to assume that we're not missing some Tylenol or secret substance. Lymphoma seems less likely with the lack of B symptoms, lack of lymphadenopathy. Hemolytic anemia, less likely based upon my smear and the pattern of hyperbilirubinemia. Again, cancer, I'm going to assume that's not hidden from me based on a right quadrant ultrasound. autoimmune diseases have been evaluated with our serologies, and the pattern of disease for dermatomyositis, the dermatologic pattern just doesn't fit. I don't think it's sarcoidosis, and I'm going to assume that it's not two separate processes causing all these things. So where does that leave me? That leaves me with porphyria and alcoholic hepatitis, and some combination of the two. So now I really have to think more about this porphyria. And is that really what's going on? And if it is, porphyria is a broad category of diseases, and I have to really narrow it down and figure out what my best diagnostic test is going to be. And I also have to reckon with this. So I said that this is what I was initially thinking when I went through my history, and the first things came to mind. So I have to reckon with, is this just based upon the biases that I had going into this case? So do I think that I anchored on this diagnosis? Do I think I came up with premature closure, or am I just relying on my availability bias? And I think that hopefully I've convinced you guys that I went through a thorough differential diagnosis and really thought through the case in a systematic way to try to avoid biases before finally narrowing down back to these diagnoses. And hopefully that hasn't played a role in making a wrong diagnosis in our patient. But if I, of course, don't get the diagnosis right, then I have to go back and rethink these things and think about how this might have played a role in me maybe devaluing or some signs and symptoms and putting more weight onto others as I anchor. So I thought this was a good way to look at different porphyria types and to really focus on the clinical features. So along the bottom are the types of porphyria that you can see the abbreviations here as the key. And if I look at the key findings that fit with our patient, he really has erosive photodermatosis. He does not have the acute attacks given in the history, and he does not have the chronic neuropathy given in the history or on physical exam. So it really helps us narrow down to one of these 5 diseases that are associated with the blistering photodermatoses. These other 2 are associated with acute painful photosensitivity, but classically not with a blistering rash. And if I look at these a little bit closer, again, looking at just the blistering photosensitivities, out of these, if I had to pick one, and from what I could tell from my reading, there's no great way to differentiate all of these based off history or physical alone. And really, you have to get diagnostic testing to narrow down your differential diagnosis, because there are specific patterns that you'd see of porphyrin excretion that would, because there's a specific enzyme deficit for each one. So I'll start with the hereditary coproporphyria and variant porphyria. These are the ones that, if you remember from this slide, are going to have the overlap, where more commonly they're going to be associated with the acute attacks and the chronic neuropathy. So given that these are normally associated with those, I'm going to say that these are less likely for our patient. The other ones that I think are less likely based off numbers alone, so congenital erythropoietic porphyria, that's rare. There are 200 documented cases of this in the world. It's also because it's congenital, tends to come on earlier and to have more severe symptoms. So based off of that, I'm going to say that's probably less likely. So that really leaves me with porphyria cutanea tarda and hepatoerythropoietic porphyria. Both of these seem to fit with our patient, but hepatoerythropoietic porphyria is extremely rare. There are only 40 cases worldwide ever documented. And porphyria cutanea tarda has this susceptibility factor so that alcohol abuse can make it worse. And so that really seems to fit the best with our patient. That also can be familial. So based off of that and just the numbers game of that being much more common, I'm going to go ahead and say that my diagnosis is familial porphyria cutanea tarda that's been exacerbated by alcohol abuse. And my diagnostic test is going to be plasma and urine porphyrins and a plasma fluorescent spectrum evaluation to look for which specific porphyria is being caused. And with that, I will turn over to our content expert.
Thank you so much, Dr. Leroux. That was an incredible and very impressive journey through your critical and clinical reasoning and thinking. So now I will introduce our audience to our faculty content expert, Dr. Alden Chesney. Dr. Chesney is a graduate of the University of Havana, where he subsequently completed specialty training in laboratory medicine in 1988. He practiced in his native country of Guyana, and in 1995 proceeded to the Barnes Jewish Hospital in St. Louis, Missouri for fellowship training in hematopathology. After a period of observership at Sunnybrook Health Sciences Center, Dr. Chesney attended the Albert Einstein College of Medicine and Montefiore Medical Center for residency in anatomic and clinical pathology, and in 2003 became the first fellow in hematopathology at VCU. After 12 years in the clinical pathology department at Sunnybrook Health Sciences and at the University of Toronto, Dr. Chesney returned as associate professor and director of laboratory hematology in the laboratory medicine division of the Department of Pathology. He is involved in undergraduate and graduate training and is actively engaged in collaborative research in hematologic diseases and remains interested in laboratory medicine in general. It is my honor to welcome Dr. Chesney as our faculty expert.
Thank you very much, Dr. Zhang. And I have to say that Dr. Leroux has certainly elevated the bar here, but I do appreciate his extensive review of these elements because I think he's actually made my work so much easier. So let me just share my screen here. No. Okay. So in this case of this 26-year-old man with jaundice, weight loss, and fatigue, in the next few minutes, I'll try to quickly outline the lab workup of porphyrias, review something of the histopathology in this particular case, and describe some of the epidemiology of protoporphyrias with particular regard to the prevalence of hepatic involvement, and give an outline of the management of porphyrias and protoporphyria. So the porphyrias are disorders of heme synthesis occurring in all racial and ethnic groups. There are acute forms which occur in about 1 to 2 of every 100,000 or so people in North America. Higher incidences are in the Scandinavian countries, particularly Sweden, where acute intermittent porphyria is the predominant.
Dr. Chesney, I'm sorry, I'm not sure if the slides are sharing properly. It's showing the Word document I sent you.
Oh, okay. Let me view that. One moment. That should be okay now?
Yes, now we can see it.
Okay. Yes, so where was I? The highest incidence of porphyrias occur in Sweden, where acute intermittent porphyria is the predominant type of porphyria, and South Africa, where porphyria cutanea tarda is the more commonly observed form of the disease. These diseases are diseases that involve specific enzymes in the biosynthetic pathway for heme. So let's look at the porphyrin heme biosynthetic pathway. The pathway actually has these 8 different steps catalyzed by 8 different enzymes. A deficiency or an abnormality in any of which can lead to a form of porphyria. The rate limiting and first step in this pathway occurs in the mitochondrion, and in this step, succinyl coenzyme A and glycine are condensed with the participation of aminolevulinic acid synthase into 5-aminolevulinate. And the subsequent series of reactions take us through a concatenated cycle of reactions leading to the formation of heme, which, as we all know, is so important as the prosthetic group for hemoglobin, where heme forms the pocket in which iron is tasked with the transport of oxygen around the body. So if we look at each one of these enzymes and imagine some defect in each or any of these enzymes, we have 8 opportunities for a porphyria to occur. Let's look at this differently. The steps are all shown here on the left, beginning with glycine and succinyl coenzyme A catalyzed by delta-aminolevulinic acid synthase, and all the subsequent enzymatic steps. Each of these enzymes on the right-hand side have been reported in various forms of porphyrias. Important to note that the final product, heme, actually is involved in a negative feedback loop that inhibits the activity of delta-aminolevulinic acid synthase. The signs and symptoms, as Dr. Leroux mentioned, are so protean in the porphyrias that it is almost it's not possible, just looking at the signs and symptoms, to precisely identify which form of porphyria is most likely operative, although there are some clues. So the symptoms, which usually start from early childhood, as young children and toddlers venture outdoors, consist of the stinging, burning, itching of sun-exposed skin. The onset after sun exposure varies, but could be as brief a period as within 10 minutes. Older children and adults, particularly those with darker skin, may handle being outdoors for longer periods. I suspect our patient having darker skin may have been able to handle some of this, but still we can see that he has some skin damage. Because an infant's skin shows little more than mild swelling and erythema, the problem may be termed sun allergy and may persist for many years before a diagnosis is advanced. With repeated injury, there is the likelihood that the skin changes that we see in our index patient, the mild hyperkeratosis, lichenification, may develop over the knuckles and in areas of the face, such as around the mouth. A key element in recognizing the porphyrias is often this description by the patient of a cola-colored urine or dark-colored urine. We don't have a great deal of precision from this patient as to this discolored urine, but this could be an important element in recognizing a porphyria in any particular patient. This urine sample in a test tube as seen on the right in a darkened room might actually show some degree of fluorescence, as these porphyrins are imbued with a natural fluorescence. So the pathophysiology then is a deficiency or a defect in any one of these enzymes, which with often or without an environmental or physiologic trigger causes stress or imbalance in the heme pathway or a metabolic bottleneck because of overproduction of one of the pathway metabolites or a spillover of porphyrins and porphyrin precursors into various tissues. When that occurs in the blood, the porphyrias will react with sunlight, causing skin lesions. That overproduction or spillover may occur in the liver, and the porphyrin precursors will cause a variety of usually acute neurologic symptoms. And in the bone marrow, the porphyrin precursors can also cause a variety of acute neurologic symptoms. So notice that the final sort of the end point of the alterations leads to a constellation of symptoms that is relatively undifferentiated as to which specific type of porphyria is present. A classification of porphyrias that is very useful is looking at which organ exhibits the enzyme deficiency or defect. Is it in the red cells? Is it in the liver? Or is it mixed? One can also look at the organ where the symptoms are most manifest. In some cases, it's going to be the skin. If the skin is where the symptoms are most manifest and the most accused symptoms from the patient are these bullous lesions, the stinging, the painful sun exposures, then porphyria cutanea tarda, and so on. These are the ones that one would think about. And in hepatic, if the liver is the organ where the symptoms are most manifest, then acute intermittent porphyria and so on are the ones to be thought of. The clinical presentation, however, is probably most useful to the clinician. Acute presentations or chronic presentations. Classic acute presentations are known for acute intermittent porphyria, which is among the most common, as well as hereditary coproporphyria, which is rather uncommon. But chronic presentations are fairly common for the porphyria cutanea tarda, and as well as erythropoietic porphyrias and others. So if we look at the classification from that point of view, then we are able to address the issue of identifying which specific type of porphyria a patient might have. So in acute intermittent porphyria, which is, as we said, the most common porphyria, skin symptoms are not common, but what's common are these acute painful episodes, acute episodes of abdominal pain, nausea, and vomiting. In variegate porphyria, where skin symptoms can occur, then there are going to be acute presentations with bullous skin lesions. And similarly, in hereditary coproporphyria, which, as I said, is rare, the skin symptoms with acute presentations and bullous skin lesions do occur. Recognizing this sort of acute presentation or the non-acute presentation, which comprehends the remainder of the porphyrias, is perhaps the most useful way to address porphyrias from a practical clinical standpoint.
Dr. Chesney, this is Dr. Bergman here. We're over, it's 1:07. Let's, with maybe 3 more minutes, we can wrap up this portion. If people have to run, we understand if there are clinic obligations, but we'll just, folks want to stay tuned. I think it's a really good overview. So thank you, Dr. Chesney.
And thank you. I'll try and speed things up a little bit. So based on that sort of practical clinical approach, this group from the Italian group on porphyrias provided this sort of algorithmic approach to arriving at a diagnosis. If the prevailing manifestations are acute, an acute neurologic attack, with or without cutaneous symptoms, then measure urine porphyrins, quantify porphobilinogen and ALA. If those are elevated, then measure stool porphyrins to differentiate between AIP, VP, and HCP, because we do have one of the acute porphyrias. If there are cutaneous symptoms in sun-exposed areas, on the other hand, with skin fragility, blistering, erosions, or scarring, measuring urine porphyrins and stool porphyrins is the most useful approach. If they're normal, then porphyria is excluded. If they're elevated, then we have a cutaneous porphyria, and we measure stool porphyrins to differentiate between porphyria cutanea tarda and variegate porphyria and hereditary coproporphyria. In the middle, we have cutaneous symptoms in sun-exposed areas, some manifestations of stinging, burning, erythema. Measure erythrocyte protoporphyrin, particularly if the patient is in the pediatric age. If those are normal, erythropoietic porphyria is excluded. If they're elevated, erythropoietic porphyria is confirmed. This sort of algorithmic approach based on the clinical presentation is quite useful. Biochemical tests for porphyria are based on the Watson-Schwartz and Hoch screening tests, which are historic. Currently, there's a porphobilinogen trace kit, which is a fairly sensitive and specific kit test that can be performed in serum or in urine. But biochemical analysis and mutation studies are the gold standard for diagnosis, together with the clinical manifestations. If porphobilinogen is elevated and the patient has symptoms of an acute attack, one needs to commence heme therapy as soon as possible. Acute attacks of porphyria have elevated mortalities in the 20% range. So here we can look at the acute porphyrias and urine testing. And we can see that in our patient, there's elevated delta aminolevulinic acid. Porphobilinogen is normal, so PBG was normal. Uroporphyrin is normal. And I don't think we did coproporphyrin. But the uroporphyrin, coproporphyrin, and protoporphyrin would be normal or only very slightly elevated in ALAD deficiency porphyria. So protoporphyria, in the case of our patient, Dr. Leroux correctly recognized that there seemed to be an X link in our patient. This is an abnormality in the delta aminolevulinic acid synthase enzyme, ALAS2. There are other enzymes that may be associated with protoporphyria. So congenital erythropoietic porphyria and erythropoietic protoporphyria may also produce similar manifestations. As we said, this disease occurs in all ethnic groups. And the highest incidences are in Sweden and South Africa. Ethiopia is not one of the countries known to have an elevated incidence of these diseases. Protoporphyria is notable for overproduction of protoporphyrin in bone marrow. The classic form is a deficiency of ferrochelatase, and the result is elevated protoporphyrin levels in red blood cells, and that can be measured. Erythrocyte protoporphyrin levels, diagnostic. Uroporphyrinogen 3 synthase deficiency is congenital erythropoietic porphyria. It is rare. Notwithstanding its rarity, it has certainly entered the general sort of culture on account of some of the more manifest expressions of the disease, such as the erythrodontia seen here, where these the porphyrins are incorporated into the developing teeth. These patients may also have excessive development of the incisors, and of course, they also have the photosensitivity, and therefore don't generally come out much during the daytime, as a character we see here that's well known to cinema goers. In the case of our patient, in which the disease is X-linked, this is not a deficiency, but rather a gain of function mutation of delta aminolevulinic acid synthase 2. This is an X-linked protoporphyria, and it affects both males and females. The incidence and prevalence is unknown. There are just very few families. In fact, there's only about 10 cases known throughout the world. Males usually develop a severe form of the disorder. Females with ALAS2 mutation range from asymptomatic to rarely developing a severe form of the disorder, likely due to lionization. In the case of this patient's mom, we understand she has some mild skin manifestations, and she probably is on that milder spectrum of an ALAS2 mutation. These are the usual skin features seen in this case, reported in the Journal of Pediatrics. Some relatively small damage to the skin seen here over the face, the forehead, and damage to the hands, particularly over the carpometacarpal joints or the phalanges. Elevated erythrocyte protoporphyrin 9 levels is the major determinant of disease severity, and the risk of liver dysfunction in patients with EPP or X-linked protoporphyria is directly linked to that elevated erythrocyte protoporphyrin level. This is what the liver of our patient looked like. At the top left here, we show the bile pigment as well as protoporphyrin pigment dilating and blocking bile ducts and dilating bile canaliculi and hepatic sinusoids. We can demonstrate that some of these elements are pigments that are porphyrin pigment because they typically polarize in this Maltese cross configuration under polarizing light microscopy. So these are protoporphyrin pigment deposits in the liver. The liver of this patient, as we recognize from his labs, there is clearly liver damage, and there is here extensive fibrosis demonstrated here, that bridging fibrosis by a stain for collagen. So some standard therapies is symptomatic management, avoiding hepatitis A and B by immunization if the patient has never had these, and IV heme albumin is essential for acute attacks. This melanocyte stimulating hormone analog, afamelanotide, has recently been approved for therapy. It blocks the sunlight damage to the skin. Investigational therapies, plasmapheresis, and some patients, if this liver damage should be progressive in this patient, he may need to have a liver transplant. More exciting news recently is this recent trial of this therapeutic, which is a small molecule that is an mRNA inhibitor. This small molecule inhibitor of the delta aminolevulinic acid synthase mRNA inhibits the the enzyme production and thus decreases the production of ALA and all the downstream effects caused by the overactive enzyme. So in summary, porphyrias are a varied group of rare metabolic disorders of the heme biosynthetic pathway. Patients with acute porphyrias have very elevated levels of metabolic precursors, aminolevulinic acid, porphobilinogen, etc. The clinical presentation is due to the underlying genetic defect modified by various metabolic and environmental factors, such as the fact that our patient was imbibing alcohol in excess. They're often not diagnosed or misdiagnosed, therefore awareness is vital. And the treatment is unique to each porphyria, but generally involves educating the patient about avoiding triggers, sun exposure, drugs, alcohol, and so on, and supportive therapy. And more recently, we've got these newer agents that are likely to be very important in the arsenal that's available to us. And I'll stop here and thank you very much for your kind attention.
Thank you so much, Dr. Chesney and Dr. LaRoe. Dr. Zhang, do you have any other comments? I think we're at the end of the hour, and I was just watching some of the Twitter comments on your presentation. Phenomenal job. Many people on Twitter have commented on both of you all's excellent overview of this group of disorders. So thank you so much for the thorough presentation. Dr. Zhang, do you have anything else you want to close us out with?
No, I don't. I just really appreciate everyone participating, and really thank you so much, Dr. LaRoe and Dr. Chesney, for being here and really knocking this CPC out of the park.
Thank you.
Thanks.
Thank you both for your time. I know it took some effort to prepare all of this, so we appreciate it. And I'm sure we could circulate your slides and presentations to the internal medicine residency department so folks could review it on their own. A lot of important information. Thank you all so much. We'll stick around for a few minutes if there are any last minute questions. Otherwise, thank you so much. This concludes the Grand Round session. Thank you.